People experiencing severe mental illnesses, such as schizophrenia spectrum disorders, bipolar disorder, and major depressive disorder, experience physical health comorbidities which contribute to a 10 to 30 year premature mortality gap. The rates of cardiovascular disease, coronary artery disease, type 2 diabetes, and metabolic syndrome are at least twofold higher in people with severe mental illnesses compared to the general population. High-intensity interval training, or HIIT for short, has been shown to improve physical and mental health in healthy populations and those with cardiovascular and cardiometabolic diseases, and preliminary work has shown that it may have similar benefits in people experiencing mental illnesses. Focus groups within patients with severe mental illnesses, healthcare professionals and informal carers have found positive attitudes towards HIIT, with beliefs that it could help patients feel more relaxed, build their fitness, and provide a break from the repetitiveness of the ward environment. This study investigates the feasibility of HIIT amongst inpatients with severe mental illnesses. The primary aim is to investigate whether HIIT is acceptable and feasible, and the secondary aim is to investigate the impact of the HIIT intervention on mental and physical health. The feasibility study follows a two-part design due to COVID-19 adaptations to design. Part A comprises a non-blinded randomised controlled trial of 12 weeks of bicycle-based HIIT delivered twice weekly compared to treatment as usual. Part B comprises a naturalistic study of inpatient HIIT, whereby participants will be invited to 2 sessions of HIIT per week. Figure 1 outlines the study procedures that will be undertaken in the RCT phase, namely, in patients with severe mental illnesses who are aged 18 to 60 years will be invited to give informed consent and complete baseline tests to assess mental and physical health. They will be then randomised to 12 weeks of HIIT or treatment as usual. Both groups will repeat baseline measures at 6 weeks and 12 weeks. Figure 2 outlines the format of a typical HIIT session. Sessions will include a 4-minute warm-up, 5 60-second bursts of cycling at 85 to 95% of heart rate peak, interspersed with 90-second rest periods, and this will be followed by a 4-minute cool-down, although sessions will be adapted for people with reduced fitness. Acceptability and feasibility will be measured using multiple primary endpoints. We will measure the proportion of wards that agree to hosting the project, the proportion of people who consent to take part, adherence and attendance rates, and the number of adverse events. Multiple secondary endpoints will be assessed during the RCT phase, including psychiatric symptoms, cognition, depression, anxiety, body mass index, blood pressure and daily activity levels. In terms of the results, the study is ongoing. We aim to recruit 40 patients to the RCT and between 6 and 8 patients to the naturalistic design. Acceptability and feasibility outcomes will be reported post-randomisation and summarised by treatment arm and study phase. Secondary endpoints will be reported as pre-post intervention change and group differences will be reported. If the HIIT intervention is found to be feasible and acceptable in psychiatric inpatient settings, there would be scope for larger scale work to evaluate the clinical and cost effectiveness of HIIT in inpatient mental health settings.